In fact, we are standing in between the lunch. That might be the only reason I think for lesser crowd. But quite interesting session actually. We would have had a more people, would have had a more interactive session just because of I think the I think this year, especially phakic IOL surgery is going to become more and more popular among ophthalmologists because of not much investment and only about the price. So I'll be talking straight away with the choosing the right patient for phakic IOL. No financial interest. So phakic intraocular lens are the clear implantable lenses that are surgically placed. Either you can place it in the antechamber, you can put the iris fixated, or you can put it in the posterior chamber without removing the natural lens, enabling light to focus on the retina for improved uncorrected visual acuity. So I think the advantages are it has got a faster visual recovery, and it's also a reversible refractive procedure. Any problem happens, you can take out the lens after the procedure. And once again, those patients, especially with a little bit doubt with the corneal thickness or with the topography, this is the best procedure I could be able to tell. So what are the prerequisites for this phakic intraocular lens? First of all, age of the patient less than 21. This is the key. And always see any refractive procedure you want to do also, you have to look at the refraction. Always, I personally feel that it should be stable refraction at least a period of 1 year, and you have to dilate the pupil to look for a real crystalline lens. And of course, nowadays I think you can give the option. Those are like straight away give the different options. Suppose someone wants to undergo, if they want the refractive procedure also, you can straight away give them. Either you can do implantable columnar lens or refractive procedure. You can give the patient choice. So I think you need to look for appropriate pupil size, especially when you are implanting these lenses. The key is adequate antechamber depth, and you need to have a look on, especially on minimum endothelial cell count. And always, of course, all these patients are having a high myopia, chances of them to have any pathology in the retina. Very important, you need to treat these pathologies. So this is about the ancillary test. Of course, specular microscopy or confocal microscopy you have to do, especially to evaluate endothelial cell count. The main thing about the antechamber depth measurement, which can be done by I think ultrasound. Of course, some of the anter-segment OCT also does the job very good. Optical biometry, and always you have to measure from the endothelium. So horizontal visible iris diameter is the key here. See what exactly US FDA approved, telling that white to white measurement with the surgical calipers, and you can cross check with the op scan. There is FDA approved white to white. You should not believe, even though I think a lot of guys might be having IOL master or some other modalities, still you should not take that white to white measurement. So what I do in my practice, normally I take a surgical caliper. You have to validate that surgical caliper. That is the key. Once you take this surgical caliper, take this white to white diameter, then write it on the paper. Once again you do it one more time, whether it's giving the same millimeters. Then you take it and put it over the simple ruler. So when you put it on the simple ruler, I think if it is correspond to the same reading in the simple ruler, that means you are doing the perfect job. Take down, I think the whole key of success of this surgery is horizontal white to white. That's it. So these are the type of phakic lens available in the market. Since I am going to talk about the different, then which is my favorite lens also I am going to tell in the end. So these are the few of the companies has come with Alcon also has come, Artisan. I think all these lenses are outdated, but these are the wide range of power available. But I am only concentrating on this particular product, that is a implantable columnar lens. I think I have used more than around 600 lenses. The greatest advantage with this, the range you can see here from -3 to I think around up to -20. toricity up to 6 diopter, and even hyperopia also you can get a wide range of power, and these are the overall diameter given by the company. So of course, once again I am talking about the, now this was the, I took from the some of the data, especially for implantable coronal lens by the some of the other company, some Indian company, but especially ICL have come, I think, -3 till -2 from -18 with 6 cylinder. It's available in the market. So how much should be the minimum antechamber depth? This is the key. I think previously some people used to put this angle supported antechamber. There you require 3.2 iris fixated. I think these two are outdated. Just for someone beginners wants to just to know about the idea about the phakic lens, I just put it. But the key is here posterior chamber phakic lens, that is 2.8 or 3. 3 is actually FDA approved, but we have been doing especially columnar lenses. I have gone up to 2.7. Even though it's not FDA approved, but the patients are coming to me follow for more than 4 to 5 years, and I don't have any problem with this. So the distance of the phakic IOL to the endothelium is very, very important. Peripheral edge always it should be around 1.5 mm. At the center always you need to have minimum around 2 mm. So let me come to the endothelial cell count. So depending upon the age and ACD, I think, see for example, the patient age is between around 21 to 28 years, should be around 3,875. Depending upon the age, I think this particular, chart will give you the overall idea how much should be the endothelial cell count. And a very important pupil size, especially in the patient selection, mesopic pupil size less than of the phakic IOL optic around +1 mm. So mainly about for posterior chamber for phakic lenses around 7 mm. This is very, very important. Always only previously people used to prefer iris fixated. I think now once again it's outdated. So what are the special indication for this phakic intraocular lens? One is keratoconus. I think I have implanted more than 20-25 cases, but still it is not FDA approved, but the patients are doing extremely well. You can even do it in post keratoplasty refractive error correction. Even a residual refractive error correction, especially in pseudophakia, you can do it. And the residual refractive error correction post laser. Some of the Indian company come with presbyopia, but I don't have any personal experience with this. But I think soon with the columnar platform, I think they are going to come with these presbyopic lenses. So in conclusion, that of course, the advantage with these phakic lenses, you can preserve the corneal sphericity, very, very important. So chances of lower optical aberration. Of course, all these patients will have a improved contrast sensitivity. And one more thing, couple of points actually yesterday I have been telling in my talk, these lenses when we implant quite close to the nodal point of the eye. Because of this nodal point of the eye, normally patients get a much, much better vision, whatever we promise to the patient. For example, I will give a couple of examples. One of the patient had around, I think, -18 with -4 diopter cylinder. Patient had a best corrected vision of around 660, and I promised the patient you will get around 660, but all of a sudden that patient got around 6-9 parts vision. Just because of these lenses will be implanted quite close to the nodal point of the eye, also that corrects the higher order aberration. And I personally feel that if you ask me after doing a 50,000 surgery, which is your favorite surgery, definitely I'll put that is columnar lenses. Implantable columnar lens is my best surgery I ever seen. I think I am not at all propaganda of any star surgical, but just this is my personal experience. The patient, I think Dr. Sanjay Chaudhary also do agree with me. Patient overall satisfaction and overall outcome results are very good. Just one, it is intraocular surgery. Probably none of my patient had any endophthalmitis case. Apart from that, I don't find any problem with these lenses. And good white to white, I think horizontal diameter give you the best result. And in my all cases, lower enhancement rates can correct any emmetropia. Of course, biotips to fine tune the result. And of course, it is a reversible procedure. So once again, I thank the Sanjay Chaudhary given me this opportunity, and over to you, sir. Any questions? Yeah, actually, see, I think if you go,
Actually, wait, before we answer that question, what we are going to do in the next is, we have changed the format of the presentation. We are going to make it interactive. So we are talking about white to white, the difficulties in white to white, and the answers. Okay.
Yes.
So I'm not going to give you a routine presentation now. We'll just answer difficult situations. Okay.
Yeah,
So
but I'll just answer his questions.
Yeah, please.
Yeah, what I exactly do, see, if you go to online, if you want to get a digital calipers from 750, I think 450 to 500 rupees, you'll get digital caliper. Best one is around 800 to 900 rupees, the digital caliper. Buy couple of two, okay. So what I do, first of all, you have to put a drop of paraffin under the supine position, under the microscope. Exactly you measure horizontal white to white diameter, okay, with that caliper. Of course, as I already said in my initial, that you have to calibrate that calipers. Once you calibrate, that means that caliper is in a perfect condition. Then once you see that, then it will come like 11.2, 11.3. Then once again, after 1 or 2 minutes, you can repeat, it will give the same reading. Then with the same reading on, take a simple ruler, that whatever the ruler, that steel ruler you get, no, put it in front of that, just compare for your satisfaction. If you do that perfect, I am telling you, your overall post-op, there is no stress at all. Wherever you find any incidence of cataract, wherever you find any incidence of low vault or high vault, all on this white to white measurement. If you do a proper white to white measurement and good refraction, I think this is the key here for success of implantable column.
I tell you, 90%, 95% calipers which are available in the market, they are not correct. They are not correct. Even if you compare, I have compared many times because previously I was getting false result in my squint surgery. So that's why I have calibrated it. So 90%, 95% of the calipers available in the market are not correct. And even if you compare on the ruler, which you are telling me, even ruler, if you see, the markings are quite thick. And that's why I think we should believe more on digital rather than surgical.
No, digital calipers.
Yeah, digital calipers.
What I told,
you were telling about the surgical calipers.
Digital calipers, I'm so sorry.
That's why I think
digital calipers is the key, sir. Digital calipers, what I do, take digital calipers, that's what available in the online. Then whatever the reading you get, digital calipers only you have to calibrate. Whatever the reading you get, the digital calipers, then you have to put it over the ruler.
I think ruler is what I feel is not more correct because rulers impression are quite wide, and if you put that one, even that surgical if you want to confirm it with that, I think this will give not very correct result.
One more thing, I think someone having a off scan in their clinic also, whatever the digital calipers gives the reading, then you can compare along with the off scan. I think, sir, your opinion regarding this?
Shall I take it in a continuity in this, and then I'll make it as an interactive thing so
Thank
that
you
can freeze some decisions on it.